Okay, I'm gonna get started. So Allie asked me to present a little bit about wounds. I don't know if everybody knows, but we do not have a wound care nurse coming anymore. And all the wound referrals will go to physical therapy. And then if they need to go outside of that, then we can refer them on. But there's not, like, Mercy's not bringing a wound care nurse in anymore. So that is the new wound care nurse / PT is me, so all the referrals will come to me instead of, that way that we made that change because I'm here pretty much every day, and if I'm not here, you know, I might be gone a week on vacation or something, but then I'm right back, and at least we can do that. And then I do have PTA Crystal Shear that will help out with wounds some, like if I'm gone. She can't do the evaluations or anything, but she can carry out treatments if we need to. And I know we've been doing it in the nursing home for a while in acute care, and then we've done outpatient too, but the nice thing is, like, you don't have to wait 2 weeks for the wound care nurse to come to get something started. So that's kind of the update there. So I'm just going to go through a little bit of like basics of wound tissue, and then we're going to do a little bit on treatment, and then just kind of some little facts or pearls about wound care. So first thing is just different types of wound tissue. The 4 that we're going to look at are epithelialization, granulation, avascular tissue, both like eschar or slough. So the first one is epithelialization. So that is shown in that picture. This, I don't have a fancy laser pointer, but this nice pink, doesn't really look that great here. It should look like pink, healthy tissue that looks more like skin, maybe like a new scar that you've seen. That is actually like the lateral regeneration of the epidermis coming in and closing that wound bed. This is really fragile skin, so we want to be sure to protect that skin. The big thing is that when you're measuring a wound, if you see that epithelialization, that's no longer included in the measurement of the wound. So the new measurement, you know, previously when this was open, you would measure all the way, you know, across, but now you would come into where that epithelialization ends before you would measure that, just for some accuracy. And then with like partial thickness wounds, this may be the only process that you see. You may never see granulation, you just may see the epithelialization just come and take over the whole thing, just a small, like just the skin regenerating. Sometimes, you know, you see like a floor burn or something. That's kind of a good example of this. You might see some scabbing or some just epithelialization coming in. You'll never see that red BB granulation with that, you know, partial thickness wounds. So then the next one is granulation. I'm sorry, these pictures aren't very bright on here. It shouldn't look like blackish purple like it looks in here. It should be really bright red, beefy, granulated, bumpy tissue. This little spot right in the center here, that is epithelialization occurring within the wound, so it doesn't always occur from the outside in. So just what you would note there's an epithelial island or epithelialization occurring in the middle. You would just measure right over that. You know, it's not 2 separate wounds. This tissue is also fragile. It can bleed really easy because it's a lot of new blood vessels, connective tissue, fibroblasts, inflammatory cells, all of that. It's fragile. We want to make sure that if we're using something like Dakins or something that is using to get off some sort of chemical debrider, that we discontinue it once we see the granulation, because that will also kill the granulation and stop the wound healing. So if we have granulation, you need to quit using any chemical debrider on it.
What kind of a chemical debrider have we ever used here? Like what would we?
Like we use Dakins, or like you might see Santil being used. We use Dakins in the nursing home quite a bit. We might use that down there, but we don't usually, while they're in more of the acute setting, we're not really looking at debriding. It's not typically the goal while they're in, like on the hospital end, unless they're coming in with a chronic wound that we're treating. You know, if it's something new, we're probably not looking at that aspect of wound care quite yet. But on the nursing home, we use Dakins a lot. One kind of warning to note, if it starts to look like what it looks like in the picture now, dark purple, not as red and shiny and beefy, that could be that we're not getting good blood supply, and we need to look into maybe some vascular studies, or we might need to start debriding, because that's actually a sign that that healing is reversing. So the next one is that avascular brown or black eschar. This usually is dead tissue, lacking blood supply. When it's like this, it's usually hard or firm. If you have nice hard eschar, the likelihood of bacteria or infection is pretty low, but if it's soft and boggy, your likelihood of infection is really high. So if it's hard, we're at low risk of infection, and we can slowly work to debride that area if that's our goal. Now in somebody who may have like, they might have like an avascular area on their foot and we're not gonna get healing, we're gonna work to put like betadine on this and just let that heal on its own. We're not gonna work to debride that and open that up to infection. So need to know the treatment goal, we'll talk about that a little bit later before we decide what we're gonna do. But there is soft, kind of boggy eschar, and that's really high risk of infection. We want to debride that as quickly as possible. In all instances of any avascular or necrotic tissue, it needs to be debrided for it to heal. So if the goal is wound healing, we need to figure out a way to debride that. So anywhere that there's that avascular stuff, the body cannot break through that necrotic tissue and allow healing to occur. So this is like the avascular slough, which you can't see that great, but it's usually yellow or white. It can be kind of slimy and loose, or it can be very adherent, looks like it's just a part of the wound. This also needs to be debrided. You can do that with multiple different ways, we'll get into that later. But a lot of, like the easiest, most common way that we see a lot of times is like a wet to dry or moist to dry dressing to pull some of that off. By the way, if anybody has questions, just interrupt me. So this is just a picture explaining that not every wound, like the first picture is every wound kind of looks like they were all on the same stage. So in this wound, you're in multiple stages. You have the slough, you have a dark, hard kind of necrotic tissue in the middle. So this is necrotic, this is the necrotic slough. You have good granulation on the edge, and you have kind of this epithelial edge and some epithelialization occurring. That's what most of our wounds look like. Most of them don't say, you know, oh, it's 100% granulation. We don't see that very often. So if you were looking at how to document that, you could say percentages, you know, a percentage of necrotic tissue, a percentage of granulation. If you aren't sure on a percentage, which in this it's really hard to kind of tell with the circular, you can just say, you know, the wound measures this, there's a large amount of necrotic eschar and slough in the center and granulation starting around the edges. So, a little bit about debridement. When you would want to debride is most of the time whenever your goal is wound healing or if there's any infection present. Even if your goal may not be wound healing, but there's an infection present, then we need to debride all that out to get rid of the infection so that it doesn't spread farther. Why would we debride? Obviously the avascular tissue is not going to heal, and the longer that we leave dead tissue somewhere, the more likely we are going to cause infection. It also continues to prolong the inflammatory phase, just delaying healing, and it just takes a lot longer with that. So anytime that we have that continued inflammatory phase, we're looking at continued opportunity for bacterial invasion, continued opportunity for infection, and then the body is just fighting itself, so we're not going to heal. Now sometimes we wouldn't debride. That is usually when the goal is maintenance and not healing. Obviously a patient who's terminally ill, we see those sometimes. We have big sacral wounds on these bedridden patients. Our goal is not to heal, our goal is to take away the pain and make the patient comfortable. Sometimes we have ischemia. Typically we see that like in the foot. Sometimes you have like, we've had incidents before, like a black toe. Our goal is not to heal it, it's just to keep that comfortable until further treatment can be done, whether that's to allow the toe to self-amputate or whether that's an amputation surgically later, and especially if they're uninfected. And then most of the time, we don't want to really push on an uninfected heel ulcer and try to debride that down, especially if they're ischemic. If you do see the wet, mushy wounds with ischemia, we do need to debride those because the presence of infection is high there. So if we have that wet, boggy heel, but we have somebody with ischemia in the foot, we still want to make that goal to heal that and debride that out. Okay, we're going to go through a few types of debridement just so you guys are all kind of familiar with what there is and what our options are. The first one is surgical debridement. This is by a surgeon in the operating room, usually under general or local anesthesia. The advantage of this is it quickly converts that chronic wound into an acute wound, so we're going to go in and damage that. So like something that you might see, I have a picture of later, is a curled epithelial edge. Those aren't going to heal because the skin thinks that it's already healed. So a surgeon will actually go in and hash around that and cause re-injury so that it starts the body healing again. And that's usually what we want to do with the surgical debridement. Otherwise, we would do this for anybody who has ischemia and it's infected, because we're not going to get good healing by allowing the body to debride or adding debriders. So we need to go in and actually surgically debride that. Somebody who may be immunocompromised, it's a good idea to do that for, because we're not going to allow more infection or possibility of bacteria to infiltrate that. Very large wounds that have a large amount of necrosis, it's not comfortable to do that conservatively, and it's going to take a really long time, where we can put them under and do it surgically and get a quicker healing. Same thing with the extensive necrosis. So the disadvantages of this is it's very costly. There's the risk of anesthesia. It must be done in an acute care surgical setting, and only a physician can perform this. Then there is conservative sharp debridement. So this is something that I can do, or a certified wound nurse. It is debridement of non-viable tissue. So I can go in and selectively debride slough or eschar out of a wound without getting into any healthy tissue, and that can be done without anesthesia. It can be done locally in the office, and it can be done by somebody on staff, and it's not very costly, so that's kind of nice for the patient and nice for us. It can be done quickly. It's a much lower cost to the patient. There's no surgical risk, and it's a lot quicker than, say, throwing Dakins in a wound and packing it and letting that happen. The risks are that we're looking at a bleeding risk and local infection risk. I don't have any way to cauterize bleeding or anything like that, so that puts it at high risk if we have a patient who is, at a high risk of bleeding or anything like that. There's also a risk of infection because we're not going to be in a sterile surgical room or anything like that. We're going to be at bedside. We are going to use sterile equipment, but we're not going to be in a sterile room, so there's a little bit of that. Usually that's done on a smaller wound, a lot of times with looser slough that we're not going to be cutting into healthy tissue. So the next type of debridement is what we use quite frequently. It's called autolytic debridement. We allow the body to debride the necrotic tissue itself. So we're going to use different bandages or dressings to allow the body enzymes and bacteria to work together to kind of eat away at that necrosis. To have autolytic debridement occur, you must have a moist wound environment. So it's not going to occur on those dry necrotic eschar. We have to get that soft and wet before it will occur. It is not effective with patients who are neutropenic because they don't have the white blood cells to help to fight that, or in an area of poor perfusion. So it's not going to work on like diabetic neuropathy patients. It's not going to do anything for us. The dry wounds, we need to add moisture. Wet wounds, we need to keep them moist but not saturated. So advantages to this is it's very low risk, very cost effective, non-invasive, no damage to the surrounding skin, no risk of damage by adding chemicals or anything like that. Easy to perform. Disadvantages is it's slower, we have an open wound for longer, so we're at higher risk of infection. And if we're going to use something occlusive, we're going to look at possibly the risk of anaerobic infection too, anaerobic bacterial invasions. So on a dry wound, we would want to add moisture. So you have a dry necrotic heel that we need to wound. We can to heal. We're going to add moisture to that. You can use a transparent dressing that's going to keep moisture in. We can also add things like hydrogels, alginates, hydrocolloids, or anything like that. The honey wound care products also have a little bit of antiseptic, so if we're looking at some risk of bacterial invasion, that can fight that a little bit too. But we're going to add that moisture, and typically with like a transparent dressing or something to hold in that moisture on those dry wounds. If we have a wet wound, we want to control that moisture without allowing the wound to dry out. So we don't want to dry that wound out completely if we're trying to debride it, so sometimes something like an aquacell might be too much when you're working on a goal of debridement. but Noctisol would be really great when you're just trying to dry it out and allow it to heal. So we're gonna add something that's absorptive and it's gonna control that drainage. If we're using foam or the Aquacell or something, we can dry that out too much and then actually gonna have to reverse it and then add something to moisture. We're just gonna have to keep going back and forth if we don't get that under control. So then chemical or enzymatic debridement, you might hear it called both ways. You're gonna use any kind of chemical agent to debride that tissue. Like we talked about a little bit ago, Santal, Dakins, those are probably two of the most common. This is really good with a large amount of necrotic tissue and that the majority of the wound bed has necrotic tissue. Like I said, if you have any granulation in there, you're going to kill all the granulation if you add in any chemical debrider. Advantages are they're very quick and you're at minimal risk to the healthy tissue. But the disadvantages, it can be expensive. Sometimes it's hard to get, we have to have a prescription, the pharmacy doesn't usually carry it, the patient has to wait a week or so before we can get it. Need to carefully apply it. We don't want to just slop it all over and get it on healthy skin and have it kind of eating away that. And then you also need to add a dressing to that. So we're looking at adding a prescription and a dressing so it can get pretty expensive. And then sometimes the debridement process by using chemicals can be pretty painful for the patients. And then there is mechanical debridement. That's use of like a wet to dry, moist to moist dressing. We're actually putting the dressing in. We're gonna rip out that slough or that necrotic tissue. It's not very selective. It's gonna take everything out, healthy and unhealthy tissue. Hydrotherapy whirlpools, we don't really use them anymore. They're expensive to maintain. They have a high risk of bacterial infection. It's real general, we're gonna debride everything. They work, but the risk of infection and the maintenance on the whirlpools is really too much that most people aren't using them anymore. Both of these, mechanical debridement options are cost effective and the dressings are simple. We're not doing a whole lot, so it's easy to use. And it's also good for wounds with a lot of necrotic tissue since it's not selective at all. But that can be a disadvantage that it's non-selective. You're ripping off healthy tissue and can be bleeding, can be really painful. Patients really don't like it very much. When you go and pull off the dressing, it's ripping off that healthy tissue, causing bleeding and stuff. And then something that we won't ever see here, but it might be something that we refer on, is the use of larval. They do have a lot better options for maggot debridement. They have them in pouches now, so you're not just throwing free maggots onto a wound and then collecting them all. They're all in pouches, and you can actually lay the pouches on the wound. And the maggots don't actually eat the tissue. They secrete an enzyme that causes healing. So you may see that if you're somewhere else. We're not gonna get them here. They're too expensive. They're not. Do you want them, Steph?
Yeah, we did it.
Yeah,
We've also done it in
Yeah.
different hospitals.
We just don't.
It looks like they're eating it though.
Yeah, it looks like they are, but they're just off. They hanging out, secreting their enzymes. It's really good because it just causes selective debridement, so it's only going to debride the necrotic tissue. And then the enzyme secreted will actually improve healing and cause quick healing. When you guys use it, did you guys have the pouches or did you have the free larva?
It was like a net thing.
Mm-hmm.
It looked like.
They have them more now. They look almost like those, what are those, silica pouches, that you might get in like new shoes or something. They look more like that and they're within there.
They escape?
No, they just stayed in this little net thing. This is what they're sitting
That's how
in.
they're using it most of the time now. They aren't using the free larva anymore. As you have maggots running around that you're trying to collect, and it's pretty gross. So obviously the disadvantage is that a lot of people, everybody's cringing at it, it's gross. A lot of people won't accept it, a lot of people don't want it for treatment. And they're hard to get and can be expensive and not available very often. Then the last kind that we won't see very often, use of ultrasound therapy to debride. There is a company and a machine called Ultrasound Mist. I had him come in and do in-service for us and was looking at getting it, but the cost is outrageous, like $30,000 for a unit.
Oh, wow.
We thought maybe $5,000–6,000. No, $30,000 was the unit that he put us on. So it's not available in very many places. I know Mason City doesn't use it. There's a lot of bigger areas that don't use it because it's so expensive. and you can't capture a lot of revenue off of it because you can't combine it with some other CPT codes, so. There's some other, E-stem, ultrasound things out there that can also be used to help promote wound healing. It's not necessarily debridement, but just promotion of wound healing. Okay, so I don't have one for the clinic yet with directions, but it's pretty much the same. I have some handouts for your nurses' stations. I will get a couple more copies of these. These are like a quick reference guide. So I'll put one for the clinic as well. The first page tells you what to do if you see a wound. So like if you're in the nursing home, you're gonna follow all the directions here. It's in the here, we'll go over it later. And you're gonna follow everything on here. And then this has pictures of what a wound might look like, and then what your first line of treatment's gonna be. So if somebody comes into your clinic, they have a wound that looks like this. It's 5 o'clock at night and Kristen's gone. What am I gonna do?
Call her at home.
Yeah. I will not be coming in, probably not. I'll tell you to refer to this sheet. So it kind of tells you a little bit of description so that you know what you're looking at, and then it's got the treatment. So, and I try to do very simple treatments that don't take a lot of thinking, and they tell you exactly what product to get, how often to change it, and whatever, and then it tells you how to get me on board for the wound care. So I have all your stages of pressure injuries on here, and then I have diabetic ulcers, venous ulcers, skin tears, and that's it. So, really good with this clip here today. Well, they work really good here. There we go. So I have a couple of those. I will have one for acute care at the nurse's station. There'll be 2 in the nursing home at each nurse's station. Then I'll get one in the clinic that you guys can refer to in case you need something. The doctors will usually make that decision for you, but if the doctors want to peek at the simple answer, then it's there. So that's something that we kind of talked about. We kind of initiated with the nursing home because something might happen at night or on the weekends, and it's like, what's the best thing so that we have consistent treatment across the board, and then we're choosing the right thing. And things change all the time in the research, so I try to go with kind of the simplest, least expensive, most widely used things, and with what products that we have on hand here, so it's easily for all of us. Alright, so now the part that probably applies to you guys a little bit more is the kind of documentation portion of it and how to document your wounds appropriately. The things that you're going to include are all the tissue characteristics, which is what we just talked about, what you see in there, what the tissue looks like, how to do measurements, drainage characteristics, condition of the surrounding skin, any indications of infection, pain, treatment and plan, and then any patient or caregiver instructions that you gave. So when you're looking at characteristics of tissue, you want to describe the tissues of the characteristics of the wound bed. So is there slough present? Is there granulated tissue present? Everything that we just went over. If you can, describe the percentage of the tissue type. That's easier if you don't have multiple tissue types. If you have something that's 25% yellow adhered slough, that you can say that. Also, if there's odor present, make sure that you note that. Because that can change day to day. Sometimes it's there just because the wound didn't get cleaned well. Sometimes it's at a risk of infection. So we want to be monitoring that. When we're measuring wounds, there are about 1 million ways. If you research how to measure a wound, you're going to find a ton of different ways. There's a head to toe way. There's longest width to longest depth, longest width to longest length. You can go through that. So for consistency, and probably the most widely used is length would equal head to toe. Even if that's not, if the wound is like this, you're going to measure head to toe, and then over width is going to be hip to hip. So try to think of that as your access, and then your depth is obviously the deepest part. So you're going to find whatever the deepest area of the wound is and measure that. We're not going to measure 6 different depths and say, well, this one was this and this was that. So if we kind of just have that access where we're looking at head to toe, hip to hip, that's your length and width. So if I have a wound that's like this, I'm going to measure head to toe, hip to hip, not longest length longest width. And then you want to measure in centimeters into the nearest tenth of a centimeter. That way we're accurate, and those are going to show big changes there. So we have this measurement tool. It's not the greatest. We also have the paper infant measuring tools. Those are easier to not make a mistake on. I see all the time people making a mistake where they go from this dot out to the 1 or out to the 2, and they go from here out to here, and they say it's a 5 centimeter wound. This center part, unless you have a perfectly circle wound, you should never use this, because this is measuring the circle. So if you think it's from dot to 1, that's really only ½ centimeter. And I see it all the time. We'll see, wound measures 3, and then we'll check it the next week, and somebody measured it as 6 centimeters. Well, that wound didn't change 3 centimeters in a week. It's an error of measuring. So, unless you have a perfect circle or you're really good at eyeballing, throw this out and use this over to the side. Or there's those infant paper measuring tools. Fold that over so that your 0 is the end of it, and use it like a regular old tape measure. That's the easiest way. And then to get a depth, you're going to take a Q-tip, put it in as far as you can, mark that spot, and then measure it. Or if it's a wide enough wound, you can stick that tape right in as deep as it'll go. So I see that error all the time. We see that all the time. Even well-educated people are like, well, that was 6 by 3, and they're using the circles. So, any questions on that? That's like a huge error I see all the time.
Well, for a perfectly circle round.
No. I don't know what that is.
Yes.
Okay, so then another thing we need to talk about is drainage. So you want to describe any of the drainage that you see, how much, and what type. The next slide's to kind of tell you what. So your types of drainage, we have serous drainage, that's clear, thin, it might have a slightly brownish color. It should be present on the wound dressing when you take it off, just looking wet. It shouldn't be real yellow. It might have a little bit of discoloration, but mostly it should just look wet on your bandage when you take it off. This is normal in the acute inflammatory stage. It's just that inflammation coming in. We should see that healing within 2 weeks. If there's really heavy amounts of drainage or it's lasting more than 2 weeks, then we need to investigate that there's likely infection present. Sanguineous drainage, that means that there's blood within the drainage. That is normal, at onset of a wound. If you have a surgical wound, if you fall and hit something, you're going to get some bleeding. This is usually seen in both partial and full thickness wounds. It can be seen. It's primarily blood. This is normal initially, but if it continues to occur or there's large amounts of drainage past a couple of hours, obviously, then our clotting's not working, and we need to look at whether there's a clotting issue, inflammatory issue, possible infection. Need to look at that. So normal at first, not normal as it goes on. Sometimes we'll get a combination of the serosanguinous where there's a little bit of blood present, but it's mostly serous. That's normal for a couple weeks during that inflammatory phase. That's okay. Purulent drainage is pus, what we all call pus. It's yellow, it's kind of thick, gross, brown, green. It is actually liquid plasma in the white blood cells. It is not a normal part of wound healing. It almost always means that there's an infection, either acute or chronic. We need to probably look at getting a wound culture on that and getting that treated. And then lymph drainage isn't always seen as commonly. It does look a little bit like pus. It's kind of yellowish, can be thick. It's not usually super odorous, and it's kind of greasy. This is actually like a lot of protein being leaked out because the lymph fluid has a lot of protein in it, and it's usually in very large amounts. So if we're seeing a lot, what you think might be pus, but it's coming out in like 1,000, 2,000 cc's per day, it's lymph drainage. Sometimes you'll see a little bit of that. We don't see it very often, but people have lymphedema and end up with a wound or a deeper wound that affects the lymphatic system. We'll see it. It's not very common, but if you've ever seen like a plasma Infusion, it looks very much like plasma. But hopefully nobody ever sees that. So, again, the picture's not great on the screen. Kind of a picture of all of them. You have your serous should look like a whole lot of nothing. The pus is going to be yellow. I don't know, this picture's not really great on here. Okay, so then when you're measuring drainage, sometimes there's a little bit of question on what we should use. Scant means that there's barely anything on your dressing. Much below 25%. So if your dressing is just barely moist, you're going to call that scant. Minimal is no more than 25% saturation. So if your dressing is damp but not saturated, you can't wring it out, you're going to probably call that minimal. Moderate would be 25 to 75%. That means that basically your dressing is soaked, it feels heavy, you might be able to wring it out a little bit. But high or copious drainage, it's going to be 75% or more. We're going to be switching bandages like crazy because they're leaking through. When you take them off, they're dripping. Those are not okay, and we need to do something about them. So we need to add some sort of intervention to those. The next part of documentation is the condition of the surrounding skin. That can just be a note that says it's normal, or it's red, it's smooth or dry. Just throw those in there so that we can know. That is a lot of times how we can tell if there's an infection present, if there's that change in the surrounding skin. Obviously you guys know the indications of infection, but if you see those, make sure you document them, and then we need to do further investigation, whether we need to do a culture, start an antibiotic, whatever we need to do there. Just a quick note, whether the patient has pain present before, after, or during the dressing changes. Sometimes people come in not painful. You do the dressing changes, say you're doing a wet to dry dressing change, we just ripped off all that scabbing and everything. It's normal that they would have pain. Or with a burn, it's normal that they would have pain. It's good to note that, especially if somebody's not having pain when you think they should, we might need to look at some neuropathy or innervation issues. You know, if we have a burn victim and they don't have pain with their dressing changes, there's probably something wrong. So note that and look into that further. Just your treatment, you know, did you cleanse the wound? What did you cleanse it with? Did you use a barrier cream or skin prep or anything around the wound to protect the skin? Did you pack the wound and how did you pack it? What type of dressing was used? When is the dressing supposed to be changed next? And is there any plan that has changed today or that you're planning to change? So if you change something today, you need to make sure that you note that that got changed. And then if you get, you know, if the patient's doing dressings at home or a caregiver's doing dressings at home, which we see a lot in the outpatient world, make sure that you're noting that you gave that education and that they understand it and know what they're doing. Give them a written copy if you can. So this is just kind of some tips and ideas of stuff that you guys might see commonly and maybe not sure what to do about it. So this is not a great picture again. Sorry, they're so dark on here. This is called Epibole, something like that. I don't know exactly. It's curled wound edges. This is where I was talking earlier, that epithelialization. Those epithelial borders actually curl down and attach to themselves. If you see this at all, this wound will not heal any further unless we intervene to this. The epithelial cells have now reached each other, and they don't know the difference whether they curled down and reach each other or if they migrated across the wound and reached each other. But if you see this, the epithelial cells all think that they're healed, and that wound's going to stay exactly like that for eternity. And it's going to have infection, it's going to get problems. So there's a couple different things that we can do to treat this. We can send them to the surgeon. They can go in and hash all the way around that. They're going to cause an acute injury and cause healing to reoccur. For patients who are not surgical candidates, or that they want to go a little bit more conservatively, we can use a silver nitrate stick and essentially burn or re-injure those cells around there to cause that re-injury to occur. Or sometimes they'll use a wound vac.
You said it was silver nitrate at one time, or how long is that?
It's usually like 7 to 10 days. We have used it for longer than that before if we're starting to get a little bit of injury, but it's definitely more than once. And if we ever need to do that, I can kind of educate you on doing it. We've done it in the nursing home before.
We have done it before.
And usually we would do it multiple days until you can see that that has been re-injured. So once we start to see red kind of like a new wound forming, then that's when you would discontinue that. And the documentation for that would be that you successfully re-injured the skin to allow for healing. So, also if you have a wound that's healing well, and then all of a sudden we see curled edges, we probably need to look at possible infection, because there might have been a bacterial invasion that caused that. Sometimes just chronic wounds that might be too dry or something, this might happen too. Another one that we will probably see commonly is diabetic ulcer. It's usually small amounts of pressure over time, usually gets calloused way up. Usually we have no idea what's underneath that because there's so much callus around it. Typically what I do with this is refer them to the podiatrist because they have a lot better tools than I do. I have a scalpel to do this with, and they have lots of little grinder tools and stuff. I don't like to go on a patient with neuropathy and start cutting away because they can't tell me if I'm getting to that healthy tissue. They can't feel that. If it was one of us in here, I'd go ahead and do it. You'd tell me right when I get to that healthy tissue and I can stop. They can't tell me when I get to that healthy tissue, and I might not know until they're bleeding and I've caused more damage. So this is usually like a weekly podiatrist visit. Go in and shave that all down, and then once they can get to the actual wound bed, then I'll treat them. The other big thing is obviously we need to offload this. We can't have them continuing to put pressure on this. I think this is probably the most common thing that we see are, moisture related wounds, surrounding skin issues. So kind of the traumatic wounds that we might see are skin tears or secondary wounds from ripping off the tape. So obviously with those we want to use something like the skin tears. That's a completely different thing than a secondary wound. Secondary wounds, we can limit those by using skin prep to harden that skin around it and to give a barrier. Minimizing how much adhesive we're placing on the patient and that kind of things. The big thing that we usually see very commonly with our elderly and incontinent patients are moisture associated wounds. You can see that redness, you see some maceration, excoriation, some lesions. Usually looks like really bad diaper rash or the skin's been ripped away. Typically, until this turns into a deeper wound, we don't want to dress this wound. The biggest, easiest thing to do is to apply barrier cream thickly to this. Apply that frequently, every time it's wiped off, and keep it covered. That's going to allow a barrier from further incontinence. It's going to allow the wound to be open to some air and allow some healing. If we put a dressing on there, we're going to retain that moisture and we're going to allow that wound to get worse. So the easiest and simplest thing is just to apply barrier cream. Also, many times if we have patients who are bedridden, we need to remember that the least amount of layers underneath them possible. So if you walked around with a plastic Ziploc bag in your pocket all day long, you would no doubt have sweat underneath that. So if we look at our Chucks pads and everything, they have a moisture barrier underneath them. So if your patient is not in